Okay, what I've done on previous cardio tests is I've had this, this is how I like it written out. It doesn't have to be a paragraph. Um, and what you'll have to do is I will have a word bank, um, but it'll obviously be in a different order. And I literally, all I need you to do is write it in order. You know, I just put these little dashes here. You don't even really have to do that. But the big thing is it is starting somewhere in the heart for our blood flow. I usually say somewhere start, I always start at the aorta. And when it leaves the aorta, that's oxygenated blood. And it's going to go to a spot in the body. And what I've written in this little handout, I just picked the kidney, but I want you to pick somewhere else. So I don't want you to use now renal is the term for anything renal is pertaining to the kidney. So the renal artery is the kidney. Now the mesenteric artery would be the intestine. The hepatic artery would be the artery going to the liver. So there's different, but all of those arteries, the carotid artery goes to the brain, and that's a branch of the aorta. So every time the aorta, when it leaves, it branches, and it's going to go to an area in the body. That first branch is quite large. When it goes into the kidney, that renal artery is going to divide and spread out into renal arterioles, which are tiny little renal arteries. And then by the time it gets to the renal capillary, that's like the net that's red and blue, it's going to drop off, and that's why I've in parentheses, it's going to drop off oxygen, and it's going to pick up CO2. So the first thing in the parentheses is what it's dropping off and then what it's picking up. And then after that capillary, it's going to go into a renal venule, which is a tiny vein. The renal vein is a very large branch, but the renal venules all come back into a renal vein, and then the renal vein joins with the vena cava. And then the vena cava, I have here, is going to come into the right atrium. It's going to go through the tricuspid valve, and it's going to go to the right ventricle. And then it goes out the pulmonary valve. I left out one thing here, and I didn't pick it up till after I'd sent it to you guys. But right after the pulmonary valve is the pulmonary artery. Okay, so right between pulmonary valve and lungs, it should say pulmonary artery. The only thing I've put here is it's after the pulmonary artery, it goes to the lungs. And inside the lungs, it's now dropping off CO2. That's why CO2 is first. And it's going to pick up oxygen. And after it does that, the pulmonary veins were the two red vessels coming back into the heart. In that picture, it's going to dump into the left atrium. Goes through the mitral valve. Mitral has an L in it, so it's on the left side. It's a little tip. And then it's going to go through the left ventricle, out the aortic valve to the aorta. So you have to include all the valves. And you see, I started with the aorta, I end with aorta. Whatever you start with, you should end with. And what this does is that's just the proper flow. Now, the only thing I've left off, next week, we start the respiratory system. I will go into the blood division and what happens inside the lungs. So for now, I just want you to put lungs, CO2 for O2, and then how it comes back. And I just put little notes here. When you leave an artery, like from the heart, it's going big to little, and then when it goes back, it's little to big. So I attached that handout yesterday with the video from yesterday's lecture. So this was just a little extra handout to kind of help explain what I want to do on the test. Now, what I usually do is this blood flow will be on at least the next 3 tests because we're going to build. So when I add the respiratory system next week, we add what happens in the respiratory blood flow. And when I do the digestive system, we write what happens in the digestive blood flow. So, we're going to keep repeating this because it's very important to understand proper blood flow. And the reason I put the little tip about, think about a red blood cell is traveling through all of these parts. And if you were someone giving directions, like if I told someone, you know, you get off at 465 East, make a right on Emerson, turn left on 10th, turn right on Breakstone Drive, and then here's my house address. I've given you every spot along the directions. And what you're doing is kind of giving directions to the red blood cell, where you're going to go out the aorta, you're going to make a right at the renal artery, then you're going to turn at the arterial, pull into the capillary, and then how do you get back? We'll get in the venule, that jumps into the renal vein, make a right at the vena cava. You know, if you think of it like giving directions, it's essentially we are tracing a red blood cell and everything where it goes and what it does. So that's essentially what we're doing. And if it helps you, yes, actually it should say after pulmonary valve, pulmonary artery. So Sean put a note in the chat. And then so I just put a note in the chat. So pulmonary valve, pulmonary artery, and then the pulmonary artery goes to the lungs. And you wouldn't put lungs first and then pulmonary artery because the pulmonary artery is going to the lungs. That would be reversed. So that's what I'm going to look for the proper flow. Let me, whoops, that's not what I wanted. This is what I want. Okay, so this is where I left off yesterday. And this is explaining that blood flow that I literally just talked about. I'm just having you use all the names of the parts. Instead of saying heart, artery, I want the specific names and the specific locations in the heart. Now, one thing that is different is the blood flow in the fetus. So in utero, the fetus has the oxygenated blood from the mother, okay? The lungs in a fetus are not exchanging O2 and CO2. That's the mother's job. So when the blood goes to the fetus through the umbilical artery and the umbilical vein, that is where the oxygenation and CO2 exchange occurs in the mother. If we look what's happening here, the lungs just need enough oxygenated blood to grow. Okay, they're not for gas exchange. They're just growing. Now, after they are born and the fetus comes out, they detach from the umbilical vein and umbilical artery. Once they detach from that blood supply, they are completely dependent on their own ability to inhale air and inflate their lungs and oxygenate. It's why it's so critical if we have animals that are in dystocia. Dystocia is difficult birth. So if we have a dog at home and they've been pushing, or one fetus comes out and they haven't had another puppy for like 2-3 hours, it's very critical that we potentially intervene, because if there is detachment, sometimes when the mother pushes, there is detachment from that placenta. And when it detaches from the placenta, it potentially detaches from the blood supply. And unfortunately, sometimes we do see dead puppies delivered, or dead kittens, or, you know, foal or whatever. But what is supposed to happen, and this happens pretty quickly after birth. It'll be easier to show you on this picture. And it looks slightly confusing. The one on the left, if you're looking at the screen, the one I'm pointing at is what's happening in utero. There's two structures that you need to understand. There's something in the middle here. It says oval foramen. Some people call it foramen. I call it foramen ovale. I've seen it written both ways. There is a hole or an opening in between the right and left atrium in the fetus. That is normal. It allows blood to move back and forth. But again, in utero, the puppy is not needing to oxygenate their own blood. The mother does that, okay? Now, the other structure that is important is we've got right here, right up here, we've got the pulmonary trunk, and this is the pulmonary artery. Now, normally, the pulmonary artery goes to both sides of the lungs, and then what happens is they oxygenate. In a puppy, you can see there's something called the ductus arteriosus, and it is open. So what is happening is some blood is going out enough blood to keep the lungs growing. And then some of that blood is joining the aorta. So there is an opening between the pulmonary artery and the aorta in a fetus, in utero, which means inside the mother. Now, after they are born, what happens here is this oval foramen or foramen ovale should close. After they take that first breath, or right as they're being born, that closes. Now, because we know blood should not go back and forth between the foramen ovale, okay, or between the atria. That closes, and now you can see the blood can do its normal flow, how we've talked about. The other thing here is here's the pulmonary trunk, all right? Now the ductus should close. So when that ductus closes, that blood no longer joins the aorta. That blood is forced to the lungs to be oxygenated. The reason this becomes important to understand is that we sometimes, now if you've ever heard of a baby being born with a hole in its heart, sometimes you hear about that in human babies, it means that this did not close, okay? So they have what's called an open foramen, and that is allowing blood to go back and forth. Now what happens is you're getting mixing of oxygenated and deoxygenated blood. So what happens here is some of this deoxygenated blood could join oxygenated blood. And we're not getting adequate blood flow, and we're not getting adequate oxygen to the tissues. What we tend to see in puppies, now a hole in the heart in a puppy, unfortunately, is probably going to mean euthanasia. Now in babies, they do open heart surgery. That's just not commonly done in veterinary medicine. One issue that we see is we see dogs that have what's called a patent ductus arteriosus. I'll type it out. Stop auto-correcting here. So sometimes we have a puppy comes in and they have a PDA. If a puppy has a PDA, what that means is this ductus remained patent or open, okay? So let's think about what happens in this puppy. Somebody adopts a puppy, maybe they're the runt, they get the puppy home and they're not eating. And they're kind of lethargic, and they're like, well, puppies sleep a lot, and my puppy goes to play and they're very winded. You know, I'm trying to play with my puppy, and my puppy's coughing, or my puppy just is exhausted, or my puppy passes out. What is happening here is that because this is open, it's going to allow deoxygenated blood to mix with oxygenated blood. Also, some of that blood is open and going into the aorta, and it's not going to the lungs. Hopefully this makes sense. If you think about if a puppy can't get oxygen, because some of that blood is being diverted away from the lungs, what am I going to see as an owner? Tired, coughing, potentially cyanotic, or, you know, they kind of look pale or muddy. It's kind of a weird, we call it a muddy color. They're just not nice bubblegum pink because they're not getting adequate oxygen. The nice thing is this is happening outside the heart. We did this surgery at Purdue. What the surgeon does is they will go in, and because this is open, they will go in and put a suture there and close that off with suture, and it's permanent suture. They use silk, and it closes it off, and then now it diverts that blood to the lungs and it no longer mixes. It's kind of cool because we would have a lot of students in the room when we would do this at Purdue. I would get tech students, vet students. I'm like, everybody needs to watch, because during surgery, their oxygen levels are not so great. Their pulse oximeter, that little thing they put sometimes a light on your finger at the doctor, they're checking your oxygen levels. And we put this on the tongue of dogs during surgery. Sometimes that number is low in these guys. And so what happens is, as soon as the doctor ties that off, all of the blood gets forced to the lungs, and all of a sudden their oxygen levels shoot up and their heart rate comes down. And it's a very interesting to see it happen live. I always tell them, the doctor goes, I'm getting ready to tie it off. And as soon as they do it, I said, everybody watch the monitor, and you see changes almost initially. So a PDA in a puppy is a very, I mean, it's not like it's a super easy surgery. It would have to be done by a board certified surgeon, but it is a fixable condition. The other thing I want you to realize is a PDA is not an old dog disease. Do you think an animal with a PDA is going to survive very long to be a 2, 3, 4-year-old dog? Does anybody want to take a stab at that? And type something in the chat? Are you? Well, exactly. So if I said, Mao, my dog was diagnosed with a PDA and he was 10 years old, true or false? False. Exactly. It's a puppy. They're going to be poor doers. And now I'm going to tell you, a lot of people get puppies and they were a runt, or they have worms, or they can have liver problems, or they can just be off. But in this dog, we would hear abnormal heart sounds, we'd get abnormal oxygen levels. It would have to be confirmed with an ultrasound. But I just want you to realize what these structures are supposed to do. Close, close. And again, it happens. Someone asked me, how long does it take? It should be pretty instantaneous. They're born, they have to start breathing on their own. They have to start oxygenating pretty quickly. Now, one thing that when you guys are taught to feel a pulse, and I get kind of stickler on this, a lot of times people will put HR, put the heart rate, or they'll put the pulse rate, PR. Sometimes people will get a heart rate by feeling a pulse. I'm like, that's a pulse rate. You have to get a heart rate by listening to the heart. Now, they should be equal. In an animal that is normal, every time the heart beats, you should feel a pulse. And you should be trained when you do a physical exam to listen with the stethoscope. And I always feel the femoral artery. And as I listen, do I feel a pulse for every heartbeat? And you're feeling the recoiling of those fibers in the artery. As the heart pulses, or as the heart beats, the arteries are going to stretch every time there's a pulse. Now, again, when you auscultate is listen with the stethoscope. You are listening to the heart. You are palpating or feeling a pulse. They should be equal. But remember, blood flow is not continuous. As the left ventricle pumps, the left ventricle has to relax. And then it pumps, and then it relaxes. Systole, diastole. That's what you're listening for. That's what you're feeling. So that's what you're looking for when you actually feel a pulse. Now, when you measure blood pressure, when we get a blood pressure on an animal, what we are measuring is the amount of pressure in the arterial, all the systemic arteries, the pressure in the systemic arteries during that contraction of the heart. When the left ventricle pumps, how much pressure is put into the arteries. Now, blood pressure this is how I look at it. If your animal has a crappy blood pressure, if we do a blood pressure and it's just awful, it's going to depend on a lot of these things. Is it because of the heart rate? Do you remember when I said the other day, I said, if you have a Great Dane that has a heart rate of 180, you have that heart's beating very fast. I told you this is diastole. Okay. The faster you make that heart go, okay, the less time the heart spends in diastole. That means that the next heartbeat, did the chambers fill enough to push out enough blood? So sometimes a dog that has a very high heart rate can have a low blood pressure because the heart is not beating efficiently. The heart is like, I can only pump out what you let me fill up with. That has to make sense. That is pure common sense. If my heart is going like this, it doesn't have enough time to fill up. Therefore, the next cycle of pushing blood out isn't going to have as much in it. And then I don't have an adequate blood pressure. Stroke volume, remember, that is the amount of blood ejected out of the left ventricle during that minute of time. But remember, I said stroke volume is dependent on preload and afterload, blood flow coming in and resistance of the artery going out. So if I have a bad stroke volume, is it preload? Is it afterload? Is it the diameter of the artery I'm pushing into? Is it too small? Is it too big? And then obviously you have to look at blood volume. If you have an animal that was hit by a car, I mean, one of the things we deal with in emergency, you have a dog hit by a car, and sometimes they come in tachycardic. Often they come in with a very high heart rate. Well, is it pain? I mean, you just got whacked by a car. You probably hurt or you're probably scared. Number one, off the bat, that's where your brain goes. Number two, though, do I have internal bleeding? Because what's going to happen, the job of the heart is to fill the pipes. I'm going to just break it down super simple. I'm a pump, and I'm connected to a bunch of tubes called vessels. If I do not have enough volume to pump, what the heart is trying to do is fill the pipes. If the pipes are half empty because half the dog's blood is laying in its abdomen, it's going to try to pump harder the heart doesn't realize that it's not there. The heart's just like, I got to pump and I'm going to try to fill it up. So the issue is, do we give that dog a bolus of fluids? One of the first things you do in emergency, and if you have an animal in shock, is we sometimes put a catheter and then we push IV fluids. What the fluids do, is it replacing blood? No. Fluids replace volume. So if you don't have enough blood, now obviously we can get into talking transfusion. The problem is, if you have a dog with an active bleed and you give it a transfusion, is it just going to dump into the abdomen? It's like a waste. You have to find out where the bleed is. And this might be emergency surgery. And you get in and you stop the bleed, but your blood pressure in the meantime needs to be good enough to have surgery. So we boost blood volume. I just want you guys, again, these are some concepts, you're just taking anatomy 2. And some of you have been in a clinic and some of you have not. But what I'm trying to build is you have to analyze what I'm talking about. You have to think about, what is the relationship of the heart and the blood vessels? It's all connected. So the problem is, when I have a crappy blood pressure, why? There is pieces to the puzzle that we have to figure out. It could be the vascular resistance. It could be blood loss. It could be, they've been vomiting for 3 days and they're dehydrated. When you're dehydrated, you don't have as much blood volume. That's why we give fluids. Okay? So when you take your fluids class, hopefully something goes ding, ding, ding. I remember we talked about this. So that's what you're measuring with blood pressure is, normally you get 3 values. If you guys go to the doctor and they put that cuff on your arm, it blows up and you're always like super uncomfortable because it's like numb. But when it squeezes and beeps, you're going to usually have a top number, a lower number. So sometimes you go to the doctor, you get a number like this, 120/70, and a mean, you get this number on the side. This top number is your systolic blood pressure. That is the pressure in your arteries when the ventricle is contracting. The bottom number is the diastolic number. This is the lower number, and that's the pressure in your arteries when your heart is in relaxation or diastole. Systolic, systole, diastolic, diastole, and then this is the average through the cycle. You do not add these numbers and divide by 2 to get that number. There is a specific calculation, okay? But your high number is always the most important. Now think about this logically. Should you have a high, should these numbers be close together ever? Anybody want to take, no. This is the pressure in your arteries when your heart is relaxing. Why would we have pressure in our arteries when our heart is chilling out? Okay, now you can have a dog that you gave too much fluids to. It's rare. I have seen dogs with those numbers close together, and sometimes what happens is there's been a fluid overload. They've received too many fluids, and what happens is you've added too much pressure to the systemic vessels, and the fluids. Here's a tube. If I add a bunch of fluid to it, I'm going to increase the fluid in there. That's going to put pressure on those walls. That's what I'm measuring. It is rare, but normally I'm most concerned with this number than I am with this. And then this number, the key, okay, the mean blood pressure, that number, we like it to be 60 or higher. In horses, they prefer it to be 70 or higher. Mean blood pressure is a representation of perfusion. Perfusion is oxygen to the tissues. If that number goes below 60, say we have an animal and they're crashing and their blood pressure is dropping and dropping and dropping. If that number goes 60, 50, 40, the body starts to go into a survival mode because there's not enough pressure to go to the whole body. So the body goes, you know what? I'm sorry, kidney. I'm sorry, liver. I'm sorry, intestine. I don't have enough blood to push to you. I got to send it to my brain, my heart, and my lungs. And what it does is it stops sending blood to other tissues. Well, the kidney, it's key to have a blood pressure higher, a mean higher than 60. After that, it doesn't send blood flow to the kidney. And what happens is you get altered renal perfusion, and then kidney cells start to die. That you can't fix that. Kidney cells don't necessarily regrow. So what happens is we cause insult to the kidneys. So when I get into blood pressure and anesthesia, or you get into blood pressure and diseases, it's very important that we have a good enough blood pressure to get adequate oxygen to our tissues. Because when it starts to fall, the body's like, it has to prioritize, okay? So I do want you to know that number. Now, I don't get a lot into this, but because I talk about this in anesthesia, but when you get that cuff that blows up automatically on your arm, that's the oscillometric blood pressure. And most monitors in anesthesia have a blood pressure cuff, and you can set it, you know, in surgery, I can set it to do every 2 minutes, 5 minutes, 10 minutes. You can do it in a different intervals. Doppler is where we put a little crystal over an artery and we can test it. But when we do a Doppler, we only get the systolic number. We don't get the other numbers. Oscillometric will give me all three, but sometimes it can be inaccurate. If you put the wrong size cuff, and those of you guys that work in a practice, and this is like my pet peeve, is the practice will have 1 or 2 working cuffs. And if you put a cuff on that's too big for the animal, you're going to get a low blood pressure. If you put a cuff that's too small on an animal, you're going to get a too high blood pressure. So normally a machine comes with 5 different sizes, and there's a little size range inside the cuff. You lay the limb inside the cuff, and if the limb fits inside the range, it's the proper cuff for that animal. So you have to do oscillometric, you have to take the results with a grain of salt. Doppler, even though it only gives me one number, systolic is very important. So that is, we use this in like exotics, small cats, or cats in general, small dogs. But a Doppler, and the Doppler is usually what we use when they come into ER to get a blood pressure. Most of the doctors will try a cuff, but I have one that I work with, and she's like, I want a Doppler. Because it's just a little more accurate. They feel a little more comfortable with that. Okay, now, how do we determine problems with the cardiovascular system? There is steps that we take, and we work our way through the problem. The first thing you do is you auscultate the thorax. You listen to the heart. One thing that you're listening for, and you're first of all listening, do you have a normal lub-dub? Do you hear clear heart sounds? You're also looking at the rate. Is it regular? I don't know if you guys have learned this in Tech 1, but have you heard of sinus arrhythmia? Did they talk about that when you guys did? Okay, so I call an arrhythmia, the definition of an arrhythmia is an abnormal rhythm, okay, cardiac rhythm. Now, a sinus arrhythmia, I call it a regular irregularity. It's an irregular heartbeat, but it happens on a regular interval. It should follow respiration, okay? So if the heart speeds up and slows down, as long as it's happening as the dog inhales and exhales, that's normal. And it tends to be seen in very young, healthy, athletic dogs, sometimes deep-chested breeds. So it's not necessarily the old guys, it's usually the very fit dog. My boxer has it. I was listening to him one night, and he, and sometimes you got to leave your stethoscope on longer to really get that. This is a take-home message for doing physicals. And this is another pet peeve, is you should be taught to count the amount of beats in 15 seconds and multiply by 4. Some people will count the beats in 10 seconds and multiply by 6. And I had an extern once, and she goes, you can also count the amount of beats in 6 seconds and multiply by 10. And I was like, well, A, thank you for telling me my job after I've done this for 25 years. B, I know how to do math, so thanks again. C, I'm going to give you a tip. The longer you listen to the heartbeat, the more you're going to pick up on rhythm. It's not only about getting a number, okay? I need to know the heart rate of a dog. Need to know it. Oftentimes, I'm more concerned, is it a normal beat? If you only listen for 6 to 10 seconds, you're getting a little snippet of a heartbeat. If I'm really concerned about a patient, I will keep my stethoscope on them for a whole minute, and I will listen. Now, I will tell you, I understand you have aggressive cats, or you have a dog that's bouncing off the walls, or sometimes you have a cat that's purring so loud, you'd be lucky to get 6 seconds or 10 seconds. There are times where you have to only listen for, obviously if the animal's trying to kill you, you got to get out of there. But what I'm saying is there is a benefit to trying to listen longer, because then you can pick up on rhythm. And hopefully that makes sense. So my preference is always, the standard 15 times 4. Sometimes I'll do 30 times 2. I'll listen for 30 seconds. But what is happening is when they inhale, their lungs are pushing on the heart. their lungs are impeding blood flow. So what happens is when the heart feels during inhale, it feels the pressure, the reduced blood flow to the heart speeds up. When the animal exhales, thoracic pressure decreases. It puts less pressure on the heart, less on the vessels, heart slows down. That's why it happens, it speeds up during inhalation and slows down during exhalation. Now, if you have a dog where the beat is all over the place and it has nothing to do with breathing, that is an arrhythmia, okay? And you should always be, it says peripheral artery palpation, okay, right here. You should be always feeling a pulse while you're listening to the heart. Again, unless you have crazy, aggressive dude or hyper lab, you should try to be listening and feeling at the same time. We always tend to get a blood pressure evaluation if we're concerned about the cardiovascular, because the consequence, if they have heart disease, is that, is it affecting blood pressure? And we need to know the level of impairment. You're going to take chest x-rays. So we're going to take x-rays of the, look for size of heart. Remember I showed you position of the heart, size of heart. I want you to be able to tell me what these tests are doing. Why am I taking an x-ray of the heart? Size, position, looking for fluid in the chest. The next test, let me talk about these next two. The EKG, which is, I talked about the electrical activity of the heart. That's all this test is telling me. And normally what you're looking for is this complex. It's called a PQRST. Now, some people call it EKG or ECG. It's fine. They're interchangeable. It doesn't matter. But what's happening is you put leads on top of the animal and they're picking up the electrical activity of the heart on the surface of the animal. A normal cycle, one cardiac cycle produces a PQRST complex. And what I teach students when you're watching an ECG, and you'll get into this in Tech 4, here's a P wave. For every P wave, you should have a QRST. P wave, QRST. If you have a P wave and you do not have this, that is called heart block. Sometimes the electrical impulse is impeded and you do not get the QRST. Well, that is different chambers of the heart contracting. So a normal ECG, P, QRST, you have a little break, P, QRST, all these boxes represent seconds. When you guys do your ECG class, Tech 4, you will learn how to, you can calculate a heart rate based on calculating the complex in those boxes. Now, obviously, most ECGs give you a heart rate, but they're going to teach you how to do, to evaluate this. Now, this is only electrical activity. If this is normal, we assume that the heart is beating or pumping. That's mechanical. This is the impulse to initiate pumping. They should be simpatico. They should be working together. Now, if we suspect heart disease, big heart, hear a murmur, crappy blood pressure, if you have the ability, then we move on to potentially an echocardiogram. Like Ireland, there was that case you talked about 2 or 3 days ago where the x-ray was abnormal or you saw the enlargement, but we talked about it could be 2 or 3 things. It could be cardiomyopathy. It could be pericardial effusion. Maybe it is a buildup of fluid in the heart. So when we see a big heart, we then have to figure out why, because there can be several reasons. The cardiac ultrasound is the gold standard, and it is called an echo, because an ultrasound uses sound waves. Echo is the sound. Sound waves bounce, they go to the heart. Certain parts of an ultrasound bounce back sound waves, okay? The more that bounces back is the more dense tissue. Like bone is bright white, muscle is going to be white to gray, and fluid is always black. So if you, if we look at this heart right here, okay, you see the chambers are black. They are filled with blood, which is fluid. Fluid does not bounce sound waves back. It absorbs it. So that is why it's black. Here, right here, this is the pericardium. This is the myocardium, okay? Pericardium is dense, fibrous tissue. It's gonna bounce more waves back. It's gonna be whiter. So that's why we call them echogenicities. It's like dark to white, shades of gray in between. We expect to see, but what this does, if I go back, is it's going to tell me the size of the heart, the shape of the heart, and an ultrasound is live. You are going to watch it beat. A true cardiac ultrasound needs to be done by a cardiologist or a radiologist. Now, if you work in emergency, sometimes we do something called a fast scan. Any doctor, and heck, I can do it. I did enough ultrasounds with my boss. I can put a probe on the heart and I can look for fluid around the heart. I'm not diagnosing anything. I'm just like, is there fluid in there? And a lot of ER doctors, we usually have an ultrasound so they can do so they can look real quick and go, yeah, there's fluid around the heart. But again, if you're doing a diagnostic to test for cardiomyopathy, stroke volume, that needs to be done by a radiologist or a cardiologist. Okay. Now, if we go one step beyond a normal ultrasound, we do what's called Doppler echocardiogram. Now, almost every ultrasound machine can give you this black and white image, live image. If we up it a notch, certain advanced ultrasound units have Doppler built in. That can actually tell us the blood flow and the color. It adds color. So here we go. Here's a heart. Now look right here. If you're watching this image, here's the left ventricle, here's the left atrium. Right there, that's a valve. What valve is that? Because it's on the left side of the heart. I'll give somebody time to type it if they want to take a stab at it. Yep, it's the mitral valve. Great. So see right here, there's a little flap. That's the mitral valve. Now, here's the left atrium. Here's the right atrium. What's going on in that circle? What did I just tell you puppies can get, or they're born with? That is a foramen ovale. Okay, that's a hole in the heart. Right there is supposed to be the interatrial septum. Is blood supposed to be able to go from the left atrium to the right atrium? It's not supposed to, okay? So right now, this Doppler live is showing you that blood, because look, it also gives you the color. Blue is supposed to be deoxygenated, red is oxygenated. Why is there red blood in the right atrium? There is your oval foramen or foramen ovale. So right there, so the nice thing with the Doppler, it can show us that there is a hole, but any ultrasound can show that hole. But if you have a Doppler with the color, it can tell you what color of blood is in that chamber. And again, that's abnormal. You're not supposed to have, you can see there's a little bit of blue right there if you're looking close enough. And we're not really supposed to have any blue blood in the left atrium. So hopefully that makes sense. And that's why an echocardiogram, it's good if you need to look to diagnose the valve disease, mitral insufficiency, stenosis, aortic, subaortic, you need to do an echocardiogram. The problem is there's not a lot of cardiologists. In fact, in our state, you'd have to go to Purdue. I will say MedVet in Carmel sometimes has a traveling cardiologist that comes to different clinics. But most people, you'd have to go to Purdue and see the cardiology department. Now, we have a radiologist at VCA. We had 2 radiologists, and they could do these ultrasounds. But if you had to meet with a cardiologist, we usually had to send the client either to Purdue or Cincinnati. Cincinnati has cardiology, and that's not too far away. Okay, let me mention briefly here for venipuncture, and when we talk about blood draws, when you guys learn to draw blood, and most blood sampling, you are working off of venous blood, which is deoxygenated blood, but that's the standard. The only time you should be hitting an artery for a sample is if you need to do something called a blood gas. And a blood gas is going to give you oxygen levels of the animal because arteries carry oxygen. Every other time you're supposed to be hitting a vein. So in the cat, the gold standard is going to be the jugular and the cephalic. The other thing that we do is on the inside of their back leg, they have something called a femoral vein, because that's the femoral area for the femur. So that if you lay a cat on its side, you'll learn about and look at the femoral vein. Now, near their stifles, sometimes you see the vein. That's a medial saphenous. As you get closer to the stifle, the femoral vein is going to narrow, and then it's going to branch into a medial saphenous. But I would say in a cat, you have to be able to tell me some blood sites that you need to draw blood. Now, in a dog, you have a jugular vein. Jugular is always a good choice. Cephalic vein, but they have a vein near their hock that you can see on the outside. That's the lateral saphenous. A cow has a jugular, and they actually have a tail vein. You can lift a cow's tail on the ventral aspect right in the medial, right where the tail head, if you lift up where the tail comes into the body, they have a vein that runs medial. You can use that in rats too. In rats, we usually use the coccygeal vein. Now in a horse, we're kind of stuck, but it's a beautiful jugular vein. You're not going to do anything to their legs to draw blood. You're certainly not going to go near their tail. So in a horse, it's pretty much venipuncture is going to be in the jugular. Now there is a milk vein that runs along an udder in a cow if you absolutely couldn't draw, but if you have a lactating cow, which means you have the female, she's got the big udder, there is a giant vein that wraps around it that's called the milk vein. But that's not used a lot. And then again, coccygeal in the rodents. So I do want you to be able to tell me some veins. I think, do I still have everybody on here? Do I have a good amount of people? I must have everybody because we have 21 participants. If everybody's still listening to me and you didn't pass out or leave the room, I think what we're going to do, since I just got to the end of this, you got to get to your other class, because Nima is going to be pissed if people are late. I'm just going to tell you that. So I usually give a little more wiggle room to people being late. She is a stickler. So yeah, people, she'll take off participation points and those add up. So I don't do that. She does. Anyway, we're going to move the test to Tuesday. So we're going to move it back a day till Tuesday. So what I want to do on Monday, did everybody get that message? I can unmute I'm going to unmute everybody. So watch what you say for a second because I'm going to unmute everybody.